obesity is a clear problem in the United States, and for a variety of patients it can be a particular complicating problem. And so we're here to talk about a JACC simultaneous publication out of this meeting here at the ACC 2015, Long-Term Effect of Goal-Directed Weight Management in AF, and this is Legacy. And this is Dr. Rajeev Pathak, who is a cardiologist and an electrophysiology fellow, and his boss, Professor Prashanthan Sanders, who is also an MD but also PhD, and both are from the Center for Heart Rhythm Disorders in the University of Adelaide in Australia. Tell me about Legacy. Let's start there.
So this is a study looking at the long-term effect of weight loss and impact on atrial fibrillation burden. We have, this is a registry-based report where we had 1,415 patients, out of which we found 825 had BMI more than 27. All these patients were counseled on the importance of weight and risk factor management. 355 of them we could, after excluding patients with severe medical condition and permanent atrial fibrillation, we had 355 patients. These patients were then divided to look at the dose-response effect of weight loss. So less than 3% weight loss, 3 to 9% weight loss, and more than 10% weight loss. And we found significant improvement in their metabolic profile, in the structural parameters, as well as there was a dose-dependent effect on atrial fibrillation burden. So
now, in the case of the directed management, how does that defined in terms of this study?
So what we do in the directed management is really we have a separate clinic that runs a weight and risk factor management side. They don't manage the fibrillation that these patients had. That's managed by the electrophysiology team. So in this clinic, we get to know our patients, we get to know their diet, we get to know their exercise regime, and we really aim at setting them goals together with them. So it's a bit of a partnership so that they can then go and achieve their goals. We can then review what happens with their diet and exercise over that time and make suggestions on how they're able to change this. And what we found is this is a really effective way of gaining compliance with patients, motivating them to take control of their disease, and they not only lose weight, but in this study, in the Legacy, we were able to show that at 5 years, most of these patients were able to keep that weight off and keep their AF away. So this was kind of an important finding for us in the Legacy study.
What is it that helps drive this weight loss? What's your secret? Because God knows the rest of the world needs an answer to this question.
So look, as Professor Sanders was talking about, this is a very simple clinic. We have one patient, one physician. We do not have any props. Basically, we work with the patient. We discuss the strategies, areas where we can improve, and with the patient in consultation and agreement with them, come up with a meal plan, which is low carbohydrate, low fat, a high protein diet. And really more important, along with that, they are asked to maintain a lifestyle journal where they're going to log everything they put in their mouth. So that helps us to look at their diet and give them necessary advice. But more importantly, for themselves, they can self-reflect and look at them and make changes. So it's a patient takes himself making those changes. And we found this as a very effective behavioral tool to make changes. And this has been really effective, not only in making them lose weight, but because they are in charge of their own health and weight loss. And with this much encouragement and involvement, that helps us to, they do not fluctuate and they keep the weight off.
What's the intersection where obesity and it starts to affect AF and vice versa?
Yeah, so I think that the data is there now from large population studies which really link obesity with atrial fibrillation. We have actually found that in our data in terms of losing weight, we haven't found much of a benefit coming down below a BMI of 27. And that may be because our numbers are lower in the BMI less than 27. So our aim really is first to lose 3% of weight. We then aim to lose 10% where we've seen the maximum impact, and then really to get their weight below a BMI of 27. Because once we get down below that, the added benefit in terms of their atrial fibrillation seems to be much lower. Now, we may have new data in the future as we get more numbers to refine that a bit more, but that's the state at this current point.
It's rather interesting because a lot of studies have been done trying to get apps to do the job of doctors, trying to get maybe a phone call or a text or something to help with the process. It is rather ironic that we're going back to that a one-on-one situation may be the best.
I think that helps to build up that rapport, and especially coming from a physician, it's sort of, we can talk in their language as well as as a physician trying to explain. Once you can convince them, the compliance definitely improves and increases. So that's where it is started. It's a proof of concept. Doesn't mean that it cannot be done out in public and done by others, but that has to be proven before we can really extend that to other allied professionals to be able to do this.
Now, is this something that's going to be going on that we'll be able to see some more legacy data further down the line?
So we started with Arrest AF, which was published in JACC at the end of last year. We now have legacy. We have a series of these studies that will come out over the next 2 years or so. We do want to be able to take this away from the one-on-one physician consultation in order to be able to make it available to the masses. And so I think an important step for us is to see how we can translate this into nurse practitioners delivering this, or concurrently using apps that might be able to help. Now, apps make it difficult to motivate someone to do something, and so that's where it's going to need a personal touch. But it's not to say it's not going to work. It's something that we have to prove that it can.
But it is the possibility that the personal touch certainly is a good place to start.
It's a crucial spot to start, in our opinion.
And this is a really good simultaneous publication from ACC 2015, so it should already be up online. There'll be a citation at the end. Right after I say, I'm Rick McGuire, Executive Editor, Cardiol Source World News.